Hello, and welcome back to the YWCA's Talk on Health. The Talk on Health was a program created in collaboration with the Lower Cape Fear YWCA and the Wilmington Alumni Chapter of Delta Sigma Theta. It was a program created to reach underserved populations to give them good and reliable information about medical issues. Today's topic is HIV and AIDS. I'm going to begin with a land acknowledgement. The YWCA of Lower Cape Fear serves the people located within the Lower Cape Fear region. This land once thrived with life from indigenous peoples, known today as the Cape Fear Indians and the Waccamaw Siouan Indian people, living in established settlements along the Cape Fear River and Lake Waccamaw, along with many other established sites in the region. We need to protect and honor the history of these places. Indigenous peoples are not relics of the past. They are still here, continuing to demonstrate their talents and gifts amidst the backdrop of ongoing colonialism and oppression. They are worth celebrating. We hope that our land acknowledgement statement will inspire others to stand in solidarity with Native nations. Thank you very much. We are recording this talk on March the 10th, and today is National Women's and Girls HIV Awareness Day. It is sponsored by the U.S. Department of Health and Human Services Office on Women's Health. In 2020, more than 5,000 women received an HIV diagnosis in the United States. Women also represented 23% of the almost 1.1 million people living with diagnosed HIV at the end of 2020. Black women remain disproportionately affected, accounting for 54% of the diagnosis of HIV infection among women in 2020. That's why we are so delighted to have our panelists today. I'm going to have to read their bios. Our first panelist is Dr. LaShonda Wallace. She is an advanced practice nurse at Novant Health, the founder and the executive director for Seeds of Healing. Dr. Wallace's advocacy and service focus on achieving health equity and improving health for marginalized populations. Seeds of Healing is a not-for-profit organization that provides HIV prevention services and promotes retention in care for Black women living with an HIV diagnosis. The core values of Seeds of Healing are awareness, assistance, advocacy, and alliance. Seeds of Healing brings HIV awareness to the community and connects those affected by the HIV epidemic to resources so that they will strive. Dr. Wallace's leadership guides Seeds of Healing to advocate for policies that address health and social needs and build alliances that synergize the commitment to sustain change. Thank you for being here, Dr. Wallace.
Thank you for having me.
Next, we have Ms. Benita Spratley. Ms. Spratley is a Black woman living with HIV for over 30 years, is an advocate working in the field of HIV for over 20 years. She has rendered services in prevention as well as clinical settings and has a passion for working diligently with those that are newly diagnosed and their families. She also has a passion for connecting those persons that are living in silence with others alike. She currently works remotely with nonprofit organizations that serve Black women living with HIV, one of those being Seeds of Healing. As a moderator for the organization's social media web-based platform for Black women living positively. This site brings Black women from around the US together through webinars, networking, and empowering one another to stay in the fight. Ms. Benita Spratley, we are honored to have you with us today. Thank you.
Thank you for having me.
Next, we have Dr. Mackie King. Dr. King is a clinical pharmacist practitioner at Novant Health, New Hanover Regional Medical Center. He graduated from the Medical University of South Carolina and completed a PGY-1 residency and a PGY-2 ambulatory family medicine residency at the University of Colorado Hospital, University of Colorado Skaggs School of Pharmacy and Pharmaceutical Sciences. He is board certified in pharmacotherapy and is credentialed as an American Academy of HIV pharmacist. He practices in an HIV clinic as well as an internal medicine residency teaching clinic. Thank you for being here, Dr. King.
Thank you for having me. I'm honored to participate in this panel with you amazing women.
Thank you. Okay. And I don't know if I introduced myself or not. I often forget that. I'm Dr. Lakeisha Jarrett, and I am a family medicine physician who works at Wilmington Health in Leland. I will be moderating today's conversation. We're going to start out with just explaining what is HIV. And anyone who wants to talk first can talk first.
I can take that. So HIV is human immunodeficiency virus. It's a virus that it attacks the immune system and definitely requires treatment. Without treatment, HIV can advance to AIDS, and AIDS is acquired immunodeficiency syndrome. And that's typically when the body has been without a healthy immune system for such a prolonged time that opportunistic infections may arise. I would just keep it there, in its simplest form. But knowing that HIV is the virus that attacks the body, and typically sometimes people get AIDS and HIV confused, but HIV is the virus and AIDS, again, is untreated advanced, untreated HIV.
Thank you.
Way HIV is transmitted. Would you like me to go into that, or I'll allow you to go ahead?
Oh, I didn't know if anyone else wanted to speak before we move on to the next part of that. But you can.
And I'll just say this simplest bit, and I'm pretty sure we're going to cover this in detail, but HIV is commonly, it can be transmitted through blood, semen, which is also known as cum, quote unquote, pre-seminal fluid, pre-cum, rectal fluids, vaginal fluids, and breast milk. But most HIV is transmitted through sexual activity with the transmission of semen and vaginal or rectal fluids.
Okay, you mentioned breast milk, so is it also transmitted from pregnant mothers to babies when they're born?
If a pregnant woman is without treatment and has a detectable viral load because she does not have access to care, or for some reason she is not on medication at that time. However, breast milk that comes from a mother who has an undetectable viral load because she is in care and she is on treatment is less likely. That breast milk is a way that it will be transmitted from a mother to a baby.
Thank you very much.
Yes.
Does anyone have anything to add to that?
No.
Okay. How do you distinguish the difference between HIV and AIDS? And does it look different clinically?
I'm going to let Ms. Benita probably chime in.
Okay, thank you. Thank you, LaShonda.
Yeah.
So a simple blood test can distinguish the difference between HIV and AIDS. You would then look at the viral load. The viral load is the actual amount of virus that's in the system, in the blood system. And anything below 200 is said to be AIDS, having AIDS. So you cannot look at a person and tell if they have HIV or if they have AIDS. You have to go by the blood work.
That is a very good point. You know, for people in the community to hear that you cannot look at people and tell if they have HIV or AIDS.
Can I just add on, if you mind, Benita?
Absolutely.
Yeah, I mean, you think about, I mean, can you look at somebody and tell when they have diabetes, right? Absolutely not. Can you look at someone and tell when they have a diagnosis of cancer? Absolutely not. However, when those ailments go untreated, unrecognized, and ignored because of whatever reasons, of course, someone will look like they may have a chronic illness. And I think that that's what sometimes causes some challenge with how people practice prevention efforts, because they're looking for something, but HIV does not have a look.
Thank you. That was a great analogy, because you know, I never really thought about that. You can actually see when someone has diabetes or cancer if it's untreated. So that was very good. Thank you.
I can also add that even the way that it shapes itself and the different symptoms and side effects that it has, you can even be said to be on drugs, because some drugs have side effects and symptoms of weight loss, hair loss, you know, all types of things that HIV you can have from HIV. So
and
I'm not just illnesses, you can be on drugs as well. So people
I
can.
I was talking to one of my patients the other day, and she was talking about how in our community, if you lose weight, it's one of two things, right?
Yes. Absolutely.
But it's not always that.
Yeah.
So that's a good point also. How is HIV treated? Maybe Dr. King can step into the conversation at this point.
Yeah, thank you. So we have some really amazing effective medications for HIV now. The landscape has really changed versus when we initially started battling and trying to treat this. There's several different classes of medications, several different kinds of medications. You know, it's potential that you could be treated with a single tablet that you just have to take one time a day, every single day. We even now have long-acting injections. So if if you're not taking any other medications, for example, you just don't think you can commit to taking medication every day, well, we have some injections where you come into the office every 2 months and get some injections instead. So the landscape, the amount of development that's gone into new medications that are much better tolerated, that are easier to take. So instead of taking 6, 7 pills a day, it may just be 1 pill a day, or these injectables. It's really changed how we treat it. And I think that patients are finding them much more tolerable than some of the horror stories that we have from the past, when they really just had so many detrimental side effects. It was really worth weighing, is it worth going through this treatment or not? Because they could provide harm at the time from side effects.
What about medications for prevention? Are there any of those?
Yeah, that's a great question. So, nothing beats the use of safe sex, so condoms, and trying to prevent it from that way. But we do have medications that can be used for prevention. And there's a couple different ways you can take those medications as well. It's very similar to some of the medicines we actually use to treat HIV, except there's just 2 medications. And historically, we use either 2 or 3 medicines to treat HIV now. But it's a tablet you can take 1 time a day. There's a specific way you can take it if you have predictable sexual encounters coming up. So, if Valentine's Day is coming up, it's going to be a special night for you. There's a way you could try to take it to kind of incorporate that event. And then similar, we also have an injectable medication that's long acting that can be used for prevention as well. So, safe sex, the use of condoms, we do have some medications that can also prevent it. There's another really important thing to consider that I'm sure we probably would plan to go on a little bit later, but I feel like now is a good time to talk about it. We also, just like medications have improved over the years, our understanding of HIV and how it works within the body has improved. And we become more aware about the rates of transmission or passing it from a person with HIV to somebody who does not have HIV. And it looks like all the data we have now tells us that if you have HIV and your viral load or the amount of virus in your body is undetectable by the lab test that we use, then it should be virtually impossible for you to transmit HIV to another person who does not have HIV. So that's another kind of arm of prevention, is really, if you have HIV, is trying to get the best control of that you can, because then that should greatly reduce almost zero chance of you passing on to somebody else if through sexual contact when that viral load is uncontrolled. Controlled.
Thank you.
Yeah.
Do you all have anything else to add to that topic before we go on?
Yes, I wanted to touch on something that Dr. King mentioned about the medications. So I was one of those that when I was diagnosed, they only had AZT. And so that was a medication that had extreme amount of side effects. When they advanced into what they called the cocktail, there was 3 medications that you would take. But however, you had to take so many of those within the course of the day. I was taking it as much as 32 pills a day. And so now that they've advanced to the 1 pill a day, it is so much more, less strenuous to me. And like, I can just take the pill and go on about my day. The side effects are less, there's less toxicity, and it's not a strain, for me to take the medications.
So you're saying that you have a lot fewer side effects with the current medication that you're taking?
Well, I have no side effects at all.
Oh,
and
okay.
Whereas before there were, some muscle aches, there were, headaches, there was, nausea and different things like that. So I don't experience anything. Now I just take my pill and go on about my day. It has even afforded me to continue to work. I raised my children, because I did have children. After I was diagnosed, and they are not positive. So even with the undetectable, the U equals U that Dr. King spoke about, undetectable equals untransmittable, I was even to have children because of the medication and taking it consistently, and not passing it on to my unborn child. And so we've made remarkable strides in HIV as it pertains to the medications and you being able to live a normal life.
Why would you not choose the injection? Or why would someone choose the injection?
For me, I wouldn't choose the injection because I'm a hard stick. So,
okay.
I just don't like my veins don't like.
Okay.
So
okay.
It wouldn't be feasible for me.
Okay, thank you.
Mm-hmm.
Dr. King, is there anyone who's more likely to be a better candidate for the injection?
Yeah, and just to clarify, so when we talk about injection, it's not an IV injection, so it doesn't go into the vein. It actually goes into the butt muscle. So it's a little bit easier than that, but still, she's shaking her head, and I understand it. Not everybody wants to get that.
Thank you for clearing that up for me.
Yeah, no problem. But still, you have to be willing, of course, to get this injection. And I don't want to sugarcoat it. It's not just 1 injection, it's 2 injections. So when you come into the office, you basically get 1 injection in each butt cheek in the muscle, because they're each 1 medication going into each one. So number 1, we have had some patients who have had a general fear of needles and in fear of injections who have actually been able to tolerate this. But when I'm thinking about evaluating who could be really good, who might be really good candidates for this, it's in general people who are not taking a lot of other medications, right? If this is the only pill, you're taking one pill a day for HIV, nothing else. Well, maybe.
So if you have diabetes and high blood pressure and a lot of other things, that wouldn't necessarily be a good medication for you.
Well, you just take away that advantage, right? So if you're only on one pill a day for HIV, you already have to take other ones. In my mind, we're not offering a huge advantage. Okay. But there's other things to really consider here. Some people view this, I've had a patient recently who said they view that pill as a constant reminder of mistakes they made in the past, or a constant reminder of their diagnosis, or a constant reminder of this. And to them, it's important not to have to face that every day. So for somebody like that, it doesn't matter how many pills you take. If you want the injection and that's what works for you, I think, we got to meet you where you are.
Right. Okay. Thank you. I never thought about that. The next question about medications I want to ask is cost, because I always, being a family medicine doctor, I know that insurance companies don't cover a lot of things, and HIV drugs are expensive. So how are they pretty well covered? Are there programs to help people for those medications?
Yeah, so, and sorry, LaShonda or Dr. Wallace, or if anybody else wants to speak in, feel free to.
We can tag team this, but you're doing so great. I'm going to allow you I'm going to let you run out the gate. Go ahead.
So the majority of insurance plans nowadays cover HIV medications to some extent, particularly if you have private insurance, if you have federal, state insurance, Medicaid. Those programs do a fantastic job of covering medications for HIV. Where it gets a little tricky is if you get into specific Medicare plans and supplemental plans and how that affects them. For patients who qualify, there are always options of medication assistance programs. So the drug manufacturers do a really good job because they understand how important it is to try to get everybody's undetectable. So, hopefully one day we can end HIV. Best way to do that is by getting everyone undetectable. So generally, manufacturers have programs that you can apply for based on income. And if you meet their income requirements, you can actually get the medication for free. We also have medications that are turning generic now. So some of these are getting a little bit more affordable compared to what they used to be as well. But a blanket statement, generally, they're fairly well covered.
LaShonda, would you like to say something else about that?
Yeah. So Dr. King is absolutely correct. Medications can be covered. However, without there being access to health coverage for all, there is a disproportionate impact among marginalized populations or disenfranchised individuals who do not have access to health care. Additionally, the point that we want to remember about those medication assistance programs, whether they be federal or funded by another cause, they may only cover that medication coverage, or they may only be limited to the doctor visit or maybe the labs. However, we know today people are living with other, comorbid conditions such as hypertension, diabetes, and they may need assistive devices for other ailments that they are dealing with. And the benefit is if people have access to cover all their circumstances and their holistic needs, because we do know that people that have a diagnosis of HIV are living healthy lives. However, they do grow older. And right now, what we do understand is that there may be a premature aging. And with a premature aging, you're going to have those circumstances that come with it. So they don't only need access to that injection or those pills, but they need everything that encompasses their healthcare so that they can have the best quality of life. And that is the piece where Seeds of Healing come in. This is our advocacy. This is what we want to make sure that our providers understand, that our leaders understand the importance of having access to not just the resources for the products, but then the know-it-all for those who are providing care, that is not just as simple as, oh, you can get that one pill and you'll be okay. Mm-hmm. There's a lot that impact the life of a person who has a diagnosis that must be considered. So it's very expensive. It can be very costly. And it is a matter of humanity in regards to how we care for our community.
Can you speak a little bit more about the premature aging that we're seeing with HIV?
Mm-hmm.
Dr. Wallace?
Want to chime in, or you want me to keep going? So if you have a diagnosis of HIV, what we do know is that, especially if it's coupled with hypertension or diabetes, there are increased risks for cardiovascular disease. For instance, there's increased risk for, progressive kidney disease. And those are circumstances, for instance, that we may see in someone who is an older adult. However, we may see them, a few years earlier. And especially if you couple it with other modifiable risk factors, such as smoking, lack of physical activity, and challenges with access to quality food, or having a lifestyle that have a habit of eating inadequate food with inadequate nutrition. So that, and then the virus itself within the body causes a premature aging. And so there's going to be some special attention that we will have to care for those who have a diagnosis.
Did anyone else have anything to add to that?
I just wanted to touch on one thing that Dr. Wallace said, just to emphasize even more. She was 100% spot on that there's so many things to consider outside of just access to a, specific medicine to treat HIV. And to take that a step further, when we look at kind of statistics and how the way that HIV care is changing over the last several years, the majority of people with HIV are not dying from HIV. They're dying from complications related to high blood pressure, to diabetes, to heart attacks, and everything else. So exactly like Dr. Wallace is saying, it becomes more about managing the other things, because ultimately the medications are effective. You can get that HIV under well control. So we start thinking about the other things that every other single person has to consider, like diabetes and high blood pressure and heart attack. So it's important that we do have to loop those into this as well.
So is HIV curable with all of these medications that we were discussing?
No, they're not curable, although we have had about 5 people that have been cured, but it was because they had cancer or a form of cancer and had to have a stem cell surgery, which is a tedious surgery in itself, and it was not to cure the HIV, but to cure the cancer. And just happenstance, the HIV was cured as well.
And that's not a fun process. You have to undergo chemo, and it basically destroys your immune system. And, so because my mind would jump to like, well, why can't I get that? Why can't I go through that and get that stem cell transplant and have that work for me?
Very expensive.
It's so expensive. And it's just, it basically destroys your body before it builds you back up. So it's not yet a feasible method where we think we can continue to reproduce this for everyone.
Right.
What other cutting edge technology or medical science is out there for treatment of HIV? Or anything else that's being researched? Are you guys aware of anything?
I mean, they have been, scientists have been making some advances with a couple setbacks and then advances with a vaccine. However, there is nothing that is remarkable to share at this time, besides the fact that there have been some attempts for development.
Yeah, they're working to explore different types of medications that would maybe work a different way in the body. There's been vaccine research, there's antibody research. So there's things in development. Unfortunately, nothing has just been very promising yet.
Okay. Is HIV life-threatening in and of itself?
Untreated, HIV, yes. It is for the person that is diagnosed. It could be for an unborn a child as well as potential partners. But if you take your medications as prescribed, and as Dr. King mentioned earlier, up to 6 months or more, you can be undetectable and not be able to transmit it to either partner or your unborn child.
Yeah,
How does it? Oh, go ahead.
I was just going to say what can happen is basically your body loses the ability to have an immune response or to fight off infections. So your immune system starts to shut down if the virus has a chance to continue to build up and up and up in the body. And something like a simple cold could even potentially lead to further infections that cause complications. So certainly, like Benita said, if it is untreated, if it remains untreated for the majority of people, we have some extremely rare other cases, but for the majority of people, it's not a matter of like if, it's a matter of when. It's going to happen.
And thank you for saying that, Dr. King, because sometimes people have the impression that a diagnosis of HIV means, oh, I'm going to die, or oh, they're going to die. But it's not something that happens overnight. Becoming progressively ill with untreated HIV can happen over a matter of years. Mm-hmm. But there's havoc that is going on in your body that you cannot see and you cannot feel. And when it comes down on you with advanced disease, there is no control. There is no prediction. You can probably see it coming after it's gotten to its advanced stages. But I just say that because people need to learn their diagnosis through routine screening. As far as a sexual health matter, it just needs to be incorporated into screening, because the earlier people know of their diagnosis, they need to start treatment right away. And so having a delay in having HIV be a part of routine health screenings is one of the reasons why HIV, the epidemic, we're still trying to end it. But if it can be incorporated and normalized as routine healthcare, then, the sooner we know, the sooner it can be cared for, and, advanced disease can be prevented.
Are nutrition and exercise important for HIV patients, and does it help them to live a healthier lifestyle?
I would definitely say yes. And Dr. King touched on a few of those reasons: high blood pressure, high cholesterol, diabetes, can all be developed while having HIV and taking your medications. And so if you can exercise and eat healthy to lessen the chances, that would be great. And some of the medications do have side effects of weight gain as well. So yes, absolutely.
Thank you. Why haven't the rates of HIV decreased?
Why haven't the rates of HIV decreased? Well, I will just say, starting off, HIV disproportionately impacts certain populations. And the reason why HIV continues to be transmitted is because of one of the things that I initially mentioned. One, having HIV screening incorporated into routine care, taking the risk, the word risk, out of circumstances where people are screened after the fact. And what I mean is People are screened when they are perceived to be at risk according to society because of maybe they are a sexual minority, or they show up to the doctor for screening for a STD. But if you don't know, you can't treat. But I'm going to say the elephant in the room is what we do know is poverty, structural barriers, those who live in remote settings, who do not have access to adequate or quality care for the screenings that we mentioned, and for the continuity of care and for initiation of care. Intimate partner violence impacts women for certain, but again, access to care by being uninsured or underinsured, inadequate education or misinformation about how HIV is transmitted. That is another reason why the epidemic has not ended. And that contributes to fear, again. So those are some of the reasons why the epidemic still exists. And we
even as a family medicine doctor, I will say that when I test people for HIV, sometimes they're, no, well, why are you checking me for HIV? So I think that there is still a stigma that we do need to get rid of in society, for sure.
Yeah. And just how you mentioned, Dr. Jarrett, not having HIV a part of a conversation of risk, but it is a part of routine care. It is a part of reproductive health. And the same way we look for CBC, right? So we get a CBC on annual visits with clients, because when something go wrong, we got a baseline that we can compare it to. So in the event that someone is unfortunately diagnosed, we can go back and we can say, a year ago, you were negative. 2 years ago, you were negative. We have a baseline, and it's a part of routine screening. It's not a part of risk. When risks come up, maybe the frequency, and again, not risk, but when certain behaviors or practices of an individual come up that pose the chance of transmission, a provider may change the frequency of screening, and then that needs to be considered.
What is the recommended screening for HIV right now?
Between the ages of 13, that should be the baseline when people should have their baseline tests, up into the age of 65, and even longer if the person continues to participate in actions or activities where HIV transmission may occur. Children.
Is it recommended annually also?
I would say annually, depending on if someone still have practices that the HIV transmission may pose that instance in their life. However, if you are a 13-year-old, you may do that baseline testing. And when you have that individual one-on-one with that individual, if you learn more, then you may incorporate it more. I would say if someone is abstinent and they've had one HIV test since the last time they participated in sex without prophylaxis or something like that, then you may test again the next year. But if they remain abstinent, if someone, I would not necessarily add on that test. But sometimes people still want testing, and then there may be other things that a provider may obtain in a health questionnaire that may say, I'm going to add this HIV test today. So it's a really case-by-case circumstance, but I do believe that providers need to be a little bit more vigilant about how they obtain a sexual history and how they obtain information about how people may use substances, the mode of use of substances, to determine the frequency for their clients.
Thank you. Does anyone else have anything to add to that? Can you tell me the numbers of the of people since this is National Women's Day, how many women, girls, and women of color live in the U.S. with HIV or AIDS?
Well, right now we have about 18% of all cases in, I think the last report in 2019 were women who had a diagnosis of HIV. However, understanding the disproportionate rate, know that Black women are 11 times more likely to have a diagnosis of HIV than our counterparts, and about 4 times as likely as our Hispanic sisters. So that just gives you a snapshot in regards to the disproportionate way that Black women are impacted. But overall, approximately 18% of those who have an HIV diagnosis in the United States are among women.
And what accounts for that disparity, Dr. Wallace?
Again, the disparity is going to be that common denominator: poverty, structural circumstances, lack of education or misinformation. And the one thing that we need to remember is stigma. And when I say stigma, being able to have that conversation comfortably without feeling ashamed or discriminated against, just by having a conversation or living with the diagnosis. Most times if someone feels stigmatized by their family members or community because they have a diagnosis or because they're seeking screening, that becomes a barrier. That becomes a barrier to getting screened. That becomes a barrier to going to your appointments because you don't want someone to know where you are or where you're seeking treatment. That becomes a barrier. People do not want their medication bottles or their prescription bottles somewhere where someone can find it. And sometimes people will fall out of care. And because of that, it's, again, U equals U. Undetectable is untransmittable. If someone is not undetectable, that risk of transmission to someone else, it remains in our community, no matter who you are.
Thank you. Bonita, do you have anything to add to any of that?
No, she cleared it up.
She cleared it up. Okay, good. So what can be done to prevent HIV and AIDS transmission? We already touched on some of it with the medication, but what other things can be done?
Get tested to know your status, use condoms, don't share needles. I would even go as far as to say, be aware if you're diabetic, be aware of family members that may have a drug injection use, because they could, get into the needles that you use to inject your insulin. And to encourage family members that are HIV positive to stay in care and to, take their medication so that they won't transmit the virus.
When we talked about medication for prevention earlier, Dr. King, who are the candidates and how would one decide whether someone should get medication for prevention?
Yeah, that's a really good question. There's a couple different people who may or may not be good candidates. So this general class of medication is called PrEP, which stands for pre-exposure prophylaxis. So it's just trying to prevent that based on, certain factors that may be involved in someone's life. So
let me interject and say, I think I've actually seen commercials for Truvada, if I'm not mistaken.
Yeah.
So, yes.
Yeah, Truvada, Descovy, those are, anytime I turn on the TV, it seems like they're coming up for sure. So there's a couple different things you may consider. If you are somebody who uses IV drugs, that is one possible route where HIV can be transmitted. So that could be something that you would consider of taking PrEP to try and prevent getting HIV, particularly using different needles. And then there's other risk what they call risk factors. So if the general categories, men who have sex with men, with multiple partners or with a partner that has HIV or who may demonstrate behaviors with multiple partners. That could be a risk factor for females who their partner has HIV, their status is unknown. If there's multiple partners, those could be some additional opportunities where you may decide if PrEP is good for you. I may have left one off, LaShawn. Dr. Wallace, if I did, please correct me. But in general, it comes down to, and most basically, it is if you're being exposed to IV drug use or multiple sexual partners where you may or may not know the status of your partner.
I mean, I feel like, though, as a family medicine doctor, anyone having sex unprotected is at risk.
Absolutely.
So it doesn't matter if you think you might know the status. And we've talked about that, like people with HIV don't look any certain way, so you don't really know their status. So
I think that's a perfectly valid point. We got that message out there, maybe, that would go quite a ways towards ending the epidemic as well.
Absolutely. You could be married or you could be in a long-term relationship, but you don't know.
Yeah.
So
I was about to say that's one of the number one reasons that people contract the virus. That's one of the vulnerabilities, thinking that you don't fit the narrative. Mm-hmm. And because HIV is out of the box, it is not just hitting a particular category or race. Anyone that is having unprotected sex or injected drug user that's sharing needles, can contract the virus. And as you said, you can be married, you can be in a long-term relationship.
It doesn't have to be multiple partners.
It doesn't have to be multiple partners.
Yeah, it only take,
one time.
And that part about substance misuse, what I will say is sometimes people can be, very careful in regards to their behaviors with substance use, but when you're under the influence, sometimes you do not have the cognitive ability to protect yourself. Mm-hmm. And that poses a risk within itself. So we also have those who may be homeless. And the reason why I bring up homelessness is because what we do know is that when people are homeless, sometimes the next resource that they do have to provide for themselves may be their own body. And that can cause a risk to get food, to get clothing or other circumstances. So those that are unhoused are at a risk. Being homeless is a risk within itself. So that is another part of the narrative that we need to make sure that we understand.
Are in heterosexual partners?
Poverty. What did you say, Dr. Jarrett?
I was saying in heterosexual partners are women, is the transmission from men to women any different than the transmission from women to men?
Transmission, women to men and men to women, there's been no difference in regards to that I would like to say, it stands out. A man can give it to a woman or a woman can give it to a man during heterosexual activity. Having the virus present in that engagement within itself is the risk. So we have to be careful how we have that conversation. But sex, whether it's vaginal sex, vaginal sex, it's heterosexual sex, it's a risk if the virus is present. Now, if you are talking about the risk factor for women, predominantly it is through their sexual engagement. Yes, right. That is a predominant risk factor for how women, and then men that have the highest rate of HIV infection, we do know is men who have sex with men, and that circumstance is caused because most instances being anal receptive, which is I would say that the activity within itself, with the friction and so forth, it causes a higher level of transmission of the virus during the activity.
Thank you.
And that activity with the anal receptive pose the same risk if you are a woman, if you are participating in being anal receptive for anyone.
What medications are now effective with HIV or AIDS? Dr. King, can you give us the names of some of the medications?
Sure, yeah. So thinking about the more recent ones moving backwards, we used to think everybody had to have at least 3 different medications to kind of target different parts of the HIV virus to be on in order to adequately control their HIV. But now we have new data that says sometimes you may only need 2. So something like a pill named Dovato or Juluca, those are kind of 2 drug combinations that you may be able to take to control HIV. Another really popular one that has been very effective, and we have some really good long-term data on, is a medication called Biktarvy, for example. And that's a 3-in-1 combination pill. But medications like Biktarvy, Genvoya, those are some of the ones that we're seeing fairly regularly. And then Cabenuva is the name of that injectable medication that I mentioned earlier.
Is there anything that prevents people from getting those medications, liver disease, kidney disease, or anything like that?
Yeah, that's a really good question. And it's possible to get kind of buried in some of the details here. If you have advanced kidney disease, we may have to change some of your medications, depending on what you're on now and what your level of kidney disease may be. That's one of the more common things that we adjust, is based on kidney disease. But there's also drug interactions that are really important. Some of our medications don't interact very well with medicines that reduce the amount of acid in your stomach, for example. So you have to space those apart, or you might not be able to use specific ones. So having that open conversation with your provider is always really important. It's a good reminder that even
to take all of your medicines to the doctor, make sure that everybody knows what you're taking.
Yeah, so if you're using Tums or something like that, that could have an effect with your medication for HIV. So you got to make sure that, your provider knows what you're taking.
Has there been any drug resistance that you know about, or?
Yeah. Sorry, Benita, were you going to answer?
No,
yes.
No, okay. I was just thinking in my mind, oh yeah.
Yeah.
Thank you, Benita.
So the idea of resistance is basically the virus kind of learns how to fight against the medication, and it can change over time to where the medication will no longer be effective. And potentially not just that one medication, but the entire class of medication that we use. And we only have so many classes of HIV medications right now. So resistance is indeed something to consider. The number one cause of resistance is not taking your medication every single day. If you take it some days, you don't take it other days. Every time the amount of virus has a chance to creep up, it's kind of like this army surrounding you that's kind of learning how it can get in, how it can learn you a little bit more. So that's why it's so important to really try to take these every single day, because when you do, it keeps that amount of virus low. Also, when you acquire HIV, you may inherit some resistance through that as well. So depending on who you got the virus from, if they have specific resistant factors, you could also have those same ones. But the number one thing to do to prevent resistance is just take the medication every single day and have that viral load uncontrolled. We do have some data. We recently got a 5-year study from one of our medications for HIV that says for the people who took it every single day, there was 0 development of resistance. So that's really promising.
And that's, someone who takes other medication, it's hard to remember to take a pill every day, but it's very, very important if you can develop resistance otherwise. So,
yeah. I would agree. Set those alarm on your cell phones, use a pill box, whatever you need to do.
Right. Okay, well, this has been a very good conversation. Thank you all for being here. Normally, I like to allow everyone to have a 1-minute thing that they would like to leave the community with, a little pearl to remember about HIV. So we're going to start out with Ms. Spratley. Ms. Benita.
Yes, so I guess I can leave something for those that may have been diagnosed. Please stay in care. Please take care of yourself. Remember self-care. Know that there are groups of people that there's an HIV community out here that's rooting for you, that's here, that you can reach out to if you need to talk with your case manager to find out about support groups. Stay active and vigilant in care, and know that you're worth fighting for.
Thank you very much. Now, Dr. Wallace.
I would like for our community to know that Seeds of Healing is here to partner with your organizations and any of our community members that want to offer HIV awareness to their constituents. If they want to incorporate an opportunity for HIV screening, it can be non-traditional hours in the evening or on the weekend. We have a wonderful team for that. They can contact us by text. They can confidentially send us messages on our inbox. We have a Facebook page, but our telephone number for text for test is 910-390-6005. In our community, I'm proud to say that we also have our New Hanover County Public Health. We have Partners in Caring. Those two agencies, as well as Coastal Horizons, also offer HIV screening in our community. We have a wonderful treatment team that is available at Novant Health as well, and the case management services that are in our community. Again, through Partners in Health, you have Life Changers, which is in the Brunswick County area. And we also have Bridges that offer case management for those who have a diagnosis. So there's a wealth of resources that do exist. And if you visit our website at at seedsofhealinginc.org, those resources are there as a reminder.
Thank you very much. And Dr. King.
Yeah, I think I would just leave with saying, despite being a pharmacist provider, I don't always think medications are the answer to everything. And I don't always try to push medications on everybody. But when we talk about undetectable equals untransmittable, that's real. And if we ever think that there's any hope of ever ending the HIV epidemic, it means that, if you have HIV, if you become undetectable, if everybody in the United States, everybody in the world had access to medications, took medication to become undetectable, then there would be no more HIV. So, if there's something that any of us can do to try and help make that better for you, please reach out. We can give additional medication access, help with that process. Our main goal is just to try to get the medications in your hands so that hopefully we can find something that works the best for you.
Thank you very much. And the last thing that I'm going to say is to get screened. Talk to your primary care physician about getting screened, and don't be offended if your primary care physician suggests that you get screened, because everyone needs to know their status in order to end the epidemic. Thank you all very much.
Thank you.
Thank you.
Thank you. Have a great day.